Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the left of your webinar screen. You may also download a copy of today's presentation using the Resources pod located directly below the Q&A pod. It is now my pleasure to introduce today's first presenter, AHA moderator, Laura Castellanos. Ma'am, you may begin.
Thank you. Hello and good day. My name is Laura Castellanos, Associate Director of the American Hospital Association, and lead the AHA's Hospitals Against Violence initiative. For this webinar series, we are proud to partner with Heal Trafficking and Jones Day Law Firm. We're working together to bring a series of educational opportunities like this one and cover a range of topics to support your efforts in combating human trafficking. Today's webinar, Promoting Prevention, Improving Health, and maximizing safety outcomes for patients affected by human trafficking and intimate partner violence. Federally qualified health centers, or FQHCs, are often the first point of contact with the healthcare system for those at risk for and affected by human trafficking, intimate partner violence, and other forms of violence. This webinar will explore the intersection of human trafficking and other vectors of violence and trauma, and how FQHCs are working with domestic violence coalitions to address this issue. We also want to take the opportunity to mention that through the efforts of the AHA, Catholic Health Initiative, and Massachusetts General Freedom Clinic, last year the CDC released the first ICD-10 diagnostic codes for classifying sex and/or labor trafficking. We're committed to continuing to raise awareness of these new codes and how healthcare providers run in a trauma-informed and person-centered way. Please visit our website to access webinars like this one, fact sheets, and other key resources. We know that together we can end human trafficking, so please feel free to contact us with any questions and feedback. It's my honor to introduce today's speakers. Anna Maryavi is the Program Director of Health at Futures Without Violence. As a Program Director, Anna provides technical assistance and program development consultation to cities, states, and American Indian, Alaska Native communities across the U.S. on addressing violence against women, children, and families. Working across public health and health delivery systems, Anna has developed national campaigns, academic conferences, and multi-state initiatives. Currently, she manages a national statewide initiative, Project Catalyst, funded by the U.S. Department of Health and Human Services agencies to engage community health centers and domestic violence programs on intimate partner violence and human trafficking interventions. Thank you for being with us, Anna. It's also my pleasure to introduce Dr. Kimberly Chang. She's a family physician at Asian Health Services in Oakland, California. In 2015, Dr. Chang completed the Commonwealth Fund Minority Health Policy Fellowship at Harvard, examining the role of FQHCs in addressing human trafficking. Previously, Dr. Chang was the inaugural clinic director at AHA's Frank Kang's Medical Center and provided care for many commercially sexually exploited children. Dr. Chang trained thousands of frontline multidisciplinary professionals on the human trafficking healthcare intersection. In August 2018, she was elected as the Vice Speaker of the House of the Executive Board of Directors for the National Association of Community Health Centers and appointed to the American Public Health Association Committees on Women's Rights. It is my pleasure to introduce Dr. Chang.
Hi. Good morning, everybody. Thank you for being here with us today. Let's see. Go and advance the slide. Okay, so I'm lucky to be here with Anna Maryavi from Futures Without Violence because we've been working together on the Project Catalyst to integrate human trafficking and intimate partner violence into federally qualified health centers and domestic violence programs across the United States and territories. We have neither of us have any financial disclosures. These are our learning objectives. We really want you to understand the role of federally qualified health centers and the intersections between human trafficking and intimate partner violence, to describe the collaborative model between FQHCs, or federally qualified health centers, and domestic violence programs, and how we work together to address all forms of violence, and to understand the Futures Without Violence Universal Education Framework to address violence, human trafficking, and intimate partner violence in healthcare settings. So just to recap, I know some of you have been on these series of webinars before, but for those of you who are new, just to recap what the definition of human trafficking is. It was first defined in federal legislation in the year 2000 under the Victims of Trafficking and Violence Protection Act. Human trafficking consists of two parts. One, it's sex trafficking, and sex trafficking is defined as a commercial sex act induced through force, fraud, or coercion. There's a second subpart of this definition, and that second subpart of sex trafficking is a commercial sex act in which the person has not yet attained 18 years of age. So it's important for you to note that sex trafficking is a commercial sex act in someone under the age of 18. And in this subpart definition, there is no requirement for force, fraud, or coercion. Any trading of sex for something of value, some commercial trading of sex by someone under the age of 18 is defined under federal legislation as a crime of sex trafficking. The second part of human trafficking definition is labor trafficking, which is the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for purposes of slavery, involuntary servitude, peonage, or debt bondage. So two parts, sex trafficking and labor trafficking, and very important to remember that sex trafficking is a commercial sex act in someone under the age of 18 without the conditions of force, fraud, or coercion. It's very important to remember that, especially in light of contemporary events that you can read about in the news. Ms. Castellanos asked me to give some examples of how I've come across patients in my clinical setting at Asian Health Services who have been trafficked or at risk of being trafficked. I'm going to tell you four patient cases. One, DH. DH was a 19-year-old transitional age youth, male. He was a male patient who, during the course of my history taking, he had been in foster care because his parents had both died. He was half Vietnamese American and half African American. He was in foster care, but once he turned 18, he no longer had housing services. So he was he had housing instability. He was coming into the clinic for some regular checkups, and I asked him during the course of my regular history taking about the possibility of trading sex for anything of value, and he basically just told me, yeah, I did it because she bought me some video games that I wanted, and this occurred when he was a minor during his time during foster care. My second patient that I want to share with you today is OT. OT was a 24-year-old G1 P0, a pregnant Chin ethnicity Burmese refugee who was coming to see me because she had severe hyperemesis gravidarum. She had severe nausea and throwing up during the course of her pregnancy. So she would have to come in regularly to get intravenous fluids and antiemetics. And so she wasn't able to work. She worked at a local restaurant. She wasn't able to work. I wrote her a note saying that she needed to be excused. She comes back the next week requiring another intravenous fluid bolus and basically is in tears saying that she brought the note to her employer and her employer got really mad and fired her on the spot, saying, we need people to work. If you can't work, you can't work here. And knowing that there are protections for pregnancy as a protected class for people, I basically wrote another note for her to the employer for this patient who did not know her labor rights, and said, hey, to the employer, hey, this is illegal. You can't fire a patient for being pregnant and having pregnancy-related complications. So she took that note to her employer, came back the next week for her intravenous fluids because she was still nauseous, and this time she's in more tears, very distraught. And when I asked her why, she basically said to me, he said that he would fire me, my husband, my brother-in-law, and all the Chin employees at the restaurant. So really holding a lot of her community hostage for reporting wage and labor violations to us at the health center. And the third patient is SD. SD was a 34-year-old Chinese immigrant woman who was sex trafficked, and there was an open case, and she was known to be sex trafficked in another county in the Bay Area. I got a call from a domestic violence advocate asking us at Asian Health Services to assume her primary care, because while she was sex trafficked in the other county, her address and her residence was in my county, in Alameda County. She resided in Oakland. And so in order for her Medicaid or Medi-Cal benefits to go through for healthcare services, she needed to come back and forth between her criminal case against the traffickers in Santa Clara County to her where she resided in Alameda County for her health care. So I get a call from the advocate to assume her primary care. And when I asked the advocate what is really her need and what's going on with her health care, the advocate basically replied that, oh, well, I'm not sure, but she's really afraid to leave the house. She doesn't trust anybody. She thinks that that people are trying to poison her food, so she's only eating ramen, and she has it all stacked up in her apartment, ramen noodles all stacked up in her apartment, and that's the only thing she is willing to eat if she prepares it herself. So when I heard that, I thought that she might be having some sort of delusions or psychoses, some sort of mental health impact. And so we got her in touch with our specialty mental health, and so she started seeing our specialty mental health psychiatry clinic here at Asian Health Services. And finally, the last patient, BK. BK was a 14-year-old Cambodian-American female who came in one night to the teen clinic very sick. She had a high fever, rashes all over her body, swollen joints, tachycardic. She could barely walk. She had lost 30 pounds over the past 3 months. And when I saw her that evening, she looked very toxic. And I told her, you need to go to the hospital. I need to send you to the emergency department because I think you're very sick and you could die. She absolutely refused, and she told me, I'd rather die than go back to jail. I didn't quite understand what the correlation was between going to the hospital and going to jail until she later revealed that on a previous emergency department visit for a miscarriage, she was sent home. She was not sent home. She was sent to the county jail because there was a bench warrant for her failure to show up to court on charges of solicitation or prostitution. Meanwhile, she's a minor. She's 14 years old, and this was in 2008, after the Trafficking Victims Protection Act had been passed. So these are the 4 patients that I would just like to share with you, and for you to think about how patients might present to you in the healthcare setting at your hospital. So why community health centers? I want to start by giving you a little history lesson that community health centers were first started out of the civil rights movement, and it was Dr. Martin Luther King Jr. who said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I would submit to you, to all of you who are healthcare professionals, that people who are at risk of being trafficked and exploited are some of the most at risk of injustices in healthcare and inequality. So community health centers started out of the civil rights movement when people were asserting their rights to healthcare. They started all over the country in little neighborhoods through community organizing. There are several requirements now that it is established in federal law under the Public Health Service Act, Section 330, for federally qualified health centers to get funding from the federal government. There are several requirements, financial, administrative, and clinical regulations that we must follow. We're required to be nonprofits. We're mission-driven. We provide service and advocacy, and we are required to see anybody, regardless of income, insurance status, immigration status. We're required to see whoever shows up, whether they can pay or not, meaning we are required to have sliding scales, and it's supposed to be very, very generous. They look at what the sliding scales are. Sometimes it's $0 copay, sometimes it's $5, $10, $15 for a visit when people are uninsured. We are required to see people who reside in medically underserved areas, or MUAs, and we are required to see medically underserved populations, and these are specified within the law. We are supposed to provide comprehensive primary care, so we are not a specialty clinic. We must provide comprehensive primary care. And finally, the most important thing that I think is special about community health centers is that our board of directors, 51%, or a majority of our board of directors, must be patients or users of our health centers. That means we are absolutely required to be accountable to our community and to the problems that are affecting the people who we see. So who is vulnerable to human trafficking? If some of you want to add in the chat box, feel free. You may have heard many of these webinars over the course of these past several months, so please chime in. So when we think about who's vulnerable to human trafficking, we often think about who is invisible or harder to see in your state. Who is vulnerable to human trafficking is basically who is vulnerable in your community. So we think about runaway and homeless youth, immigrants and refugees, documented and undocumented, Native populations, LGBTQ youth, H-2A and H-2B visa workers. For those of you who are in the webinar, you may not know the visa status or the immigration status or the documentation status, but sometimes during the course of history, you might find this out from your patients. Domestic workers. And we often think about in labor trafficking 3D jobs that are dirty, dangerous, or degrading. So I'm going to talk a little bit. Ms. Castellanos asked me to talk a little bit about how Asian Health Services started responding to human trafficking in our community. And so I'm just going to show this timeline here. It doesn't go all the way to 2019, although there's been a rash of activities in the past 5 years. But I'm just going to start with our history. We started in 1974 out of the civil rights movement, the tail end of it, and basically community activists and student activists finding out that many Asian immigrants and refugees in Oakland, Chinatown were not getting services. So we were started as a volunteer clinic in 1974. We grew pretty rapidly as the population grew within our county. And then in 1996, there was an uptick in teenage pregnancies of Asian American and Pacific Islander youth in our county. So we started a reproductive health youth program to provide education and provide some of that preventative services to our youth in our community. Once the youth started finding out about their bodies and their health care, they decided that, they started asking for services. They started asking for pregnancy tests, sexually transmitted infection tests, a birth control, and the like. So we started a confidential teen clinic in 2000. Very quickly, after we started providing services, we started seeing these trends of commercially sexually exploited children. Young Southeast Asian girls who were coming in basically revealing to us that they were being sold on the streets of Oakland for sex. We looked around. There were no services unless the children had been criminalized or arrested or been in juvenile justice. And so we decided, well, we're not going to basically send our patients to the criminal justice system when they're seeking care. So we started our own program for these children, these young adolescent youth who were being trafficked. And we started a program called Bante Sure. Very quickly, we started doing a lot of other partnerships with the Sexually Exploited Minor Network for Alameda County. We created a screening tool for clinical use in primary care settings. We started working with the National District Attorneys Association to train prosecutors and judges and probation about trauma and how commercial sexual exploitation of children was basically sex trafficking and that there were many health effects. We started working with the school districts, and then I helped to co-found Heal Trafficking in the year 2013. The things that we do that make us special, I think, in the primary care setting is that we very much do community-oriented primary care. We have integration of primary care and behavioral health. We have dental clinics. We do a lot of trauma-informed care. We take care of special populations. Across the country, 1 in 12 people are served by community health centers, 1 in 10 children, 1 in 6 people on Medicaid, 1 in 6 rural Americans, 1 in 3 who are below the federal poverty level, and 1 in 3 low-income uninsured people in the United States are served by community health centers. Asian Health Services is no different. We also have medical legal partnerships in some of them. So our approach to domestic minor sex trafficking is to do outreach. We do a lot of community outreach. We provide direct clinical services. We do prevention and health education. And we don't stop there with just services. We we know that if you don't change the systems in which you're operating and providing services, if you don't provide that advocacy and that policy work and change those systems, then you're basically just a hamster on a wheel, trying to address a problem without getting into the root causes. So we do a lot of advocacy, policy, and research to inform health policy via these vehicles. These are examples of what we do in a different format. The most important thing, I think, is the partnerships, however, because not one system is going to be able to really change the way people are exploited and vulnerable to trauma and violence in our society. We need to partner with different systems, which is why I'm very excited about the partnership that we have with Futures Without Violence. We also have partnerships with our district attorney here in Alameda County with their HEAT Watch, or Human Exploitation and Trafficking Watch, or Human Exploitation and Trafficking Institute. The partnerships are essential. We have to fill the gaps in order to provide a better safety net for our community. The healthcare intersect is very important. One study showed that while being trafficked, almost 88% of trafficked victims encountered a healthcare provider and 57% visited a clinic. Other studies, 28 to 50%. None of those were identified as being trafficked. A study that we did at Asian Health Services showed that some trafficked minors would disclose if we talked to them about it in our clinic setting. So disclosures may occur in a healthcare setting. And finally, there are models of care for victims of human trafficking and those who are vulnerable. So once disclosures occur, there are ways that we can respond. And even if disclosures do not occur, we can universally educate and provide prevention resources. And you'll hear more about that approach from my colleague here, Anna Maravi, and the importance of universal education and not relying upon a disclosure in order to get your patients the services and the resources and the help that they need. So who do they meet? This is from a great colleague of mine, Dr. McKinney Chisholm-Stricker out of Mount Sinai. She did a study of survivors, and this is who they meet. And basically, all of these types of providers fall within community health centers. I would say urgent care and emergency departments may do some overlap work. So I ask you this: is disclosure the goal? Some of you may think that identification or disclosure is the goal, and I would challenge that. I would challenge you, as you listen to the rest of this presentation, to think about, is disclosure of a patient telling you that they are in an exploitative situation or that they are being trafficked? Is that the goal? I would challenge you to think about this, because I would submit that it's not necessarily our goal in healthcare. You'll hear about the Q's approach today, which stands for confidentiality, universal education, empowerment, and support. You'll hear about that in a little bit. And the reason why I say disclosure is not necessarily our goal in healthcare is this quote from a patient of mine. I have nightmares about it. I almost died. Most times I had been with these clients, they don't really do anything to me. They'll beat me up and rape me and stuff like that, but I'm just glad I don't have no AIDS or STDs or die. So when I read this, I hear from the patient, I hear that there might be some elements of denial, some elements of normalization of the violence that she's experiencing, some elements of not knowing her rights, some elements of not knowing that this can be different and that she can have a different situation or outcome. And so if we relied on patients to provide us disclosures of their situation, we're missing a lot of people who don't realize that what they're going through doesn't have to be the way they what they're experiencing in their life. There is an intersection between human trafficking and intimate partner violence, power and control. It's basically about power and control. And the element with human trafficking is that there's a financial profit element, economic element involved as well. So you can see here the indicators for labor trafficking, lots of power and control there, and then indicators for sex trafficking, controlling or dominating relationships, abuse, lack of control of money and finances. And this is the continuum and overlap between issues. You see that labor trafficking you heard about my patient OT who was working in the restaurant. Wage and labor violations could be a precursor to labor trafficking. On the sex trafficking side, intimate partner violence could be an overlap with sex trafficking as well. I don't think of these issues as separate. I think of these issues as a spectrum and a continuum, and overlapping, and people going in and out of different types of violence. And so with that, I want to turn it over to my colleague here, Anna Mayavi from Futures Without Violence, who is leading and really directing this amazing project, Catalyst.
Thanks, Dr. Chang, and thank you, Laura. It's great to join you in Heal Trafficking today for this topic. As Kim mentioned, we're working with the Department of Health and Human Services, two agencies, the Health Resources Services Administration, HRSA, their Office on Women's Health, as well as their Bureau of Primary Health Care, and the FPHCs office under ACF, which funds domestic and sexual violence programs across the country, including coalitions and a national hotline. So our goal in doing this work, Project Catalyst, is to work with state leadership teams, people from the Department of Public Health, the Primary Care Association at the state level, as well as the Domestic Violence State Coalition. And they are reaching out and providing training and technical assistance to local domestic and sexual violence programs that are partnering up with their local community health centers. And we're really trying to work at that local level to promote the warm referrals and bidirectional warm referrals being made for clients coming into domestic violence programs, which are a primary resource also for human trafficking survivors. Many of them have been restricted from seeking primary care services for a number of reasons because of the control they were experiencing, or they had to minimize it in terms of everything else going on in their lives. So we want to increase their access to primary health care, establishing a medical home, and then addressing any of their acute medical needs. As well, on the community health center side, we want them to be able to articulate to their patients what community-based domestic violence programs offer them, all the wealth of resources, as well as connections to legal services and shelter, et cetera, and to be able to offer that warm referral over to that program. And that staff at both of those places are familiar with one another's work, have met each other, know each other by name, and know really who to direct their client to specifically. That's really how we define a warm referral. So why might a survivor choose not to disclose to their healthcare provider that IPV or human trafficking is going on? And you heard Dr. Chang mention some of the intersections in terms of the dynamics. And more, as Kim and I have gone out to the field, we've heard from a lot of domestic violence programs just around this growing intersectionality. And I think part of that speaks to the dynamic that many situations begin as relationships, especially with young people where they're groomed. And initially it may feel like it's their boyfriend, sometimes it's their husband, and they're in relationship, and then there's a lot of coercion and manipulation, and at some point something changes where they're forced or coerced into having sex with others. And it's also a piece of their survival, especially for young people who are really vulnerable, foster kids and others who are looking for a place to sleep or a shower or a meal. It can often begin just on a survival basis and then escalate from there. So we acknowledge that people's lives are complex and their experiences are very personal. And for many people, they don't self-identify themselves in these terms as a survivor of human trafficking or even as a victim of domestic violence. So there's a number of reasons why people don't share this. There's a lot of shame or judgment or stigma that they might be concerned about, especially if they don't have a long-standing relationship with their healthcare provider or have had some challenges in the past from the healthcare system. There can be very real fear or threats from their abuser or their trafficker in terms of what will happen if they do talk about what's going on. A fear of systems or police involvement because of previous experiences, bias, discrimination with those systems. Always a fear that children can be taken away and they can be removed if they disclose what's going on in terms of violence and abuse in their lives. Not knowing what will happen with the information, especially when we think about undocumented people and others who are just concerned about databases and where that information goes. You heard Dr. Chang talk about a lack of awareness of victim status and their rights, a lack of knowledge just of our U.S. laws and especially around labor trafficking, and then language barriers and illiteracy. So through this list, you can see there's a number of good reasons why people really are not always willing just to be straightforward, but still, as Dr. Chang mentioned, we can increase their awareness about safety options and decrease the isolation that they're facing by offering them warm referrals directly to community-based programs. So thinking about screening, we can learn some from our work over the last 20 years around domestic violence or intimate partner violence screening. And I think that we've learned a lot. We had started initially with very pointed, disclosure-driven questions like, have you been hit, hurt, kicked, or slapped? And just found that disclosure rates were incredibly low and did not reflect the national prevalence rates in terms of what we know about people's experience with violence. So this is a study at the top that was done with home visitors, nurse visitors, but I think there's still some learning to glean here. The use of structured screening tools at enrollment does not promote disclosure or in-depth exploration of women's experiences of abuse, and that women were more likely to discuss experiences of violence when nurses initiated open-ended discussions focused on parenting, safety, or healthy relationships. So you may be familiar with these approaches, and you may have these within your own healthcare systems currently within your hospitals. So, for example, a screening question where the partner is seated next to the client as it's asked. No one is hurting you at home, right? So kind of leading, sometimes the provider or the staff member might be uncomfortable with a question and kind of leading them. Maybe they're not ready for that answer. The second example, within the last year, has he ever hurt you or hit you with the back to the client at her computer screen? I'm really sorry I have to ask you these questions. It's a requirement of our clinic. So really not a full sort of opening conversation around what's going on. So we've shifted away from those disclosure-driven screening questions because of the low disclosures, because we found they were not as effective, because people were not receiving information when they said no. So we've shifted to an approach for patients that offers universal education. And that works for people who have never experienced intimate partner violence or human trafficking on the prevention end, especially for younger people. Those who are currently experiencing it and need, safety information, and others who have a lifetime history. We know that there's a vast health impact around these topics and a lot of chronic health issues, even if the relationship is over and in the past. So we still want to address some of that overlapping health impact. So universal education provides an opportunity for clients to make the connection between violence, health problems, and risk behaviors. And if you do have screening as a required part of your system, you can still incorporate first doing universal education and then following with a direct screen if that is important to your system. So CUES is a moniker, and it's an evidence-based intervention. It stands for confidentiality, universal education, empowerment, and support. And on the left-hand side of your screen, you're going to see a few different tools that you can click and download. And we're going to be talking in a minute about that adolescent 2017 file. You'll see it on the corner of this slide here. We're going to be looking at that. So go ahead and double-click and open that card if you can. And just to let you know, you're looking at a flat PDF, but it actually folds up to the size of a business card. It's several panels. And it's small because it actually started in the field as a tool, over 30 years ago within the battered women's movement as a shoe card, something that you could slip in and hide easily. So I want to just give you a moment to look at that card if you'd open the file. And just notice what stands out for you as you look at it. And you don't have to read it, just kind of scan it a little bit. So if you want to chat in the chat box and just share anything that's standing out to you, we can address your comments as we go. But some of the comments I typically hear when I do this with live audiences is that it begins with the positive, which is a little bit different than some other tools around this topic. So it starts more with a reflection on just how's it going in your relationship, and it talks about what healthy relationships look like. Then it talks about some of the dynamics around relationship abuse. But what you're not going to see here is language that specifically references domestic violence or human trafficking or uses those kinds of terms, what you're going to see more of is the kinds of dynamics and experiences that fall underneath that. And especially for youth, what you're looking at here is a card that can be used by either gender or any gender, any sexual orientation. It's both gender and sexual orientation neutral. And there's one panel that is on the sort of lower part of the file that's sex, power, and you. That's in the upper right-hand side. And this is the panel that gets more at some of the trafficking dynamics, especially as it relates to sex. You'll see that here. And so that's part of the universal education and also some pointed resources. And these are all national that you're seeing on the card for young people. So just to go through a few of the steps, confidentiality, you want to see the patient alone as you initiate the universal education. You always have to disclose your limits of confidentiality, and those are pretty standard if you're working for adolescents. For adults, and this came up as a question prior to the webinar, in terms of reporting requirements, that varies state by state. It looks a little different for every state. So you want to look at your specific requirements around domestic violence first, because domestic violence requirements sometimes include gunshot wounds, knife stabbings, burns on the body. And so those are always reportable offenses, but there is nothing specific to human trafficking as it relates to adults. For minors and minor trafficked victims, those minor reporting requirements that you always have if you know that someone's being hurt or harmed or is going to harm themselves, those are always mandated reports, and so that would fall underneath that clause. So the second piece is a universal education and empowerment, and we use the brochure that you were just looking at, and we give two of them. And we found by working with adolescents and focus grouping this, they continuously asked us for another card for someone in their life that they felt like needed the information. So we brought that in, and it's part of the intro, and to normalize the exchange of these cards, to say something like, and you can adapt this to your own script, I've started giving two of these cards to all of my patients in case it's ever an issue for you, because relationships can change, and also for you to have the info so you can help a friend or family member if it's an issue for them. Then you can open the card and you do a very quick review. The titles in the upper right-hand corner of each panel were actually devised also with clinicians as a way for you to just quickly touch on some key points. For example, you can say something like, it talks about healthy and safe relationships, ones that aren't, and how they can affect your health, and situations where youth are made to do things they don't want to do, and tips so you don't feel so alone. And that's getting at some of the trafficking stuff. And you can see it's a softer approach. It's not spelling out human trafficking, as many people actually are not really relating to that kind of language. And then you can say something like, on the back of the card, there's 24/7 text and hotlines that have folks who really understand complicated relationships. You can also talk to me about any health issues or questions that you have. And that's a way to keep the door open. And if they do want to talk and they do want to disclose what's going on, there's an open door there, and you also are letting them know you're a safe person for them to talk to. So it is a big systems shift for some to institute a seeing patients alone policy where, as part of every visit, whether at the beginning or end, you're seeing a patient one-on-one, because we know, especially with trafficking, you can have a lot of hovering, very concerned people who are either speaking on behalf of the client or restricting the client's ability to speak for themselves, and are very controlling in that situation. And so it's really important that as a universal measure, you're meeting with all of your patients one-on-one. And that's standardized. It's posted in your exam rooms, in your waiting areas, so that people can see that they know it's just a part of how your system operates. Traditional script for disclosing limits of confidentiality. Before I get started, I want you to know that everything here is confidential, meaning I won't talk to anyone else about what's happening unless you tell me you're being hurt physically or sexually by someone or planning to hurt yourself, and that covers the C and Qs. The universal education, it does matter how you frame it. So something like, I've started giving two of these cards to all my patients in case it's an issue for you, because relationships can change, and so you have the info to help a friend or family member if it's an issue for them. And And, I think it's worth saying that a two-card approach does tap into altruism. And, for young people or other adults who are going through trauma and abuse, it can be very uplifting and empowering for a physician or other healthcare provider to offer them this information to say, you can make a difference in the life of someone else, and here's an extra card, so you can share it. And I think that can feel very good to people and empowering. So just to read this quote here, there's a need to give, to matter, to make a difference. We find meaning in contributing to the well-being of others. So if you're concerned about how your patient is presenting, Dr. Chang offered a number of case scenarios and the ways that this is coming up with her patients. And, you may be seeing some of those dynamics and hearing, and there are ways to do some visit-specific direct inquiry and harm reduction around that and be more pointed in the way you're expressing your concern and based on, your work in this area. So you can always follow cues with direct inquiry, saying something like, I always check in with my patients and looking at the primary care level. Is there anything or anyone preventing you from getting your medication or taking care of yourself? If you're concerned about their ability to access healthcare services or follow up with next steps like going to the pharmacy and picking up medication, we know that can often be an indicator of power and control that they're experiencing in isolation. On the behavioral health side and thinking about what's going on with the opioid epidemic and other substance use, you might say something like, anytime someone is smoking or drinking or using whatever substances they're using, I always want to know how the relationship is going, because when relationships are hard, it can affect youth. And so just having it be more conversational and opening it in that way. On the reproductive health side, you might have someone, a young person or an adult coming in for a pregnancy test and they have no desire to be pregnant. Maybe they're coming in frequently for those kinds of tests, and maybe they have a contraception like birth control or they're using condoms, but they're continuing to come in or be worried about pregnancy. So saying something like, is anyone preventing you from using birth control or wanting you to get pregnant when you don't want to be? And we know a lot about reproductive coercion and have a lot of tools specifically about that, but that's people pressuring people to get pregnant or pressuring people to not use birth control when they really don't want to be pregnant. So disclosure is not the goal, and disclosures do happen. And learning from survivors, they encourage you to be non-judgmental, to listen, offer information and support, and not to push for disclosure, but to listen for what they're ready to share. So always, if someone tells you something hard in your exam room, to offer them a validating message in response. I'm glad you told me about this. I'm so sorry it's happening. No one deserves it. You're not alone. Help is available. I'm concerned for your safety. And these are very validating and can be very helpful, especially if they just shared something personal with you. And when you connect a patient to a local domestic violence or human trafficking program, it really can make all the difference. And offering your phone in your exam room, because it might not be safe for them to use their phone, or they might be worried about someone who's monitoring their phone. And offering something like, if you'd like, I can put you on the phone right now with Sally, and they can help you make a plan to be safer. As you know, there's a national human trafficking hotline. There's a national domestic violence hotline. I'm going to show you some of those phone numbers in just a moment. And it's best if you can also identify your local programs and reach out and connect with them. And advocates are really the experts in safety planning. They have vast experience around this. They also support people with housing, legal advocacy, support groups, and counseling. The other thing that I think is so key that advocates offer is perspective. So many clients that they're seeing initially come in with relationship conflicts, relationship problems, and by listening and hearing what they went through, advocates are often key in terms of recognizing overarching human trafficking dynamics, and sometimes how several clients that they're seeing might have a similar experience and actually be trafficked by the same person and not even realize the extent of the situation. And so they can be very transformative in their client's own understanding of their experience. So here's some national hotlines. You'll see some are specific to youth, sexual assault, human trafficking, also some specific hotlines for LGBTQ youth and trans folks. So just looking at the evidence quickly in support of the CUES intervention, Among women in the intervention who who experienced recent partner violence, by having received 2 of these safety cards from their provider and a little bit of information, that warm referral to a local program, there was a 71% reduction in odds for pregnancy coercion compared to control. And the women receiving the intervention were 60% more likely to end a relationship because it felt unhealthy or unsafe. So while we don't want to fix people's problems or tell them what to do, it increased women's agency, and tying, this card in particular looks at reproductive health and reproductive coercion, and they were able to see how the abuse and trauma they were experiencing was also impacting their reproductive health, and they were more inclined to make a choice to exit that relationship. The power of the CUES intervention for adolescents, using the card and looking at research from the card that you looked at with adolescents, textual harassment victimization in the past 3 months decreased from 65% to 22% in school health settings, and also in teen young adult health centers it went down. And the nice thing here, I think, is that with the 2-card approach, clients were overwhelmingly positive that they would bring a friend to the health center if they were experiencing an unhealthy relationship. So again, being that link, looking at the sort of empowerment and altruistic piece of this, they're able to also reach out to other people in their peer network and help increase their access to health and safety as well. So at our National Health Resource Center on Domestic Violence, we offer these cards for a number of specific settings and populations. We offer them for free. You can also download them as PDFs. And you can also adapt that back resources panel to be local to your community. You can add in your local hotline information, your logo. If you have any programs and information that you want to add about your hospital, you can put it there. We have a number of different tools, webinar series. We have all kinds of EHR and documentation tools, as well as reporting laws and compendia. So don't hesitate to reach out. You can see our contact information in the lower right. You can call or email, and we have a wealth of tools on our website. We're also holding a national conference on health and domestic violence next year, April, in Chicago, and our call for abstracts is now open until the end of this month. So if you're working on the intersection of human trafficking and health, we're very interested to hear more about your work. So do check out the website there, nchdv.org. This is an online toolkit that we developed with HRSA specifically for community health centers that are working with domestic violence programs. We have an additional site just for other health systems, including hospitals. That URL is ipvhealth.org. And that's a website that can help you get started around the kind of work that I'm talking about today. So in terms of defining success, success is measured by our efforts to reduce isolation and improve outcomes for safety and health. We want to grow strong partnerships between DV and human trafficking advocacy programs and your hospital systems, thinking about a CUES approach versus just disclosure-based screening alone, having that confidential environment so you can talk to patients one-on-one for part of every visit, offering them supportive messages when they do disclose or share what's going on, offering them harm reduction strategies to promote their safety and health, and nuanced ways to have conversations about how you may be concerned about what you're hearing or the intersections around the types of labor trafficking issues that Dr. Chang was mentioning. Making warm, supported referrals to your local programs, and then considering IPV and HT and your differential diagnosis as well.
So this is back to me, Dr. Chang. We started talking about community health centers and the civil rights movement is how we got to start off. So I don't want to leave you with the idea that this is an insurmountable issue or problem for our society. I mean, it's movement building. It's continuing our advocacy and our activism. Dr. Martin Luther King Jr. said, "If you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl." Whatever you do, you have to keep moving forward. So I'm so thankful and grateful to American Hospital Association, Jones Day, and Heal Trafficking for sponsoring this series of webinars, and thank you all for listening. I think we have some questions. I think a question from Dr. Stocklosa. Hi, Dr. Stocklosa. How would you recommend screening for labor trafficking? So I think, as you know, Dr. Stocklosa, that this is an area of growth and new learning, and there is no necessarily any screening for labor trafficking that I know of at this moment. However, I would challenge you to think about screening, because would there be one question that would give you a true positive or and not have any false positives or false negatives, and give you just true positives and true negatives? And so I think what I do in my primary care practice setting, and you heard about it from my patient OT, is I actually just basically do my history taking, my social history taking, my occupational history taking, my family history taking, talking to my patient about what's going on in their life. I do ask questions about if they feel like they are getting paid fairly, if they feel safe at work, what are their conditions at work when I am concerned about them. And so you know, I would say I don't think there is an easy answer in terms of screening. I would say this is our job as doctors, as clinicians, to do our history taking, to assess our patient, to talk to our patient, and to be attuned to what may be going on in their lives.
And I would add to what Dr. Chang just shared, I agree. And I think, too, what we hear and know is that many people who are labor trafficked are sometimes living in squalor that is also controlled by their trafficker, with many people to residents, sometimes with poor running water, plumbing, and even control around the food that they buy and requirements to buy lunch, for example, from their employer, things like that. So even by asking questions about where people live and identifying also issues around homelessness can be helpful. And we also hear a lot around nutrition, especially as it relates to young people really struggling as part of the experience of trafficking around their nutrition. And that could also, that food insecurity is something that can come up also in a social history taking. So those are the kinds of indicators, too, that should kind of, that you can hear, and that'll help you think more about what's really going on with your patient.
Yeah, I would agree. Did you want to comment on that, Dr. Starklosa?
Unfortunately, she won't be able to comment.
Oh, okay.
Go ahead, continue.
She could type in the question. All right. So another question: what quantitative and qualitative measurements do you use to measure outcome measures related to how you define success? I think this is regards to Project Catalyst.
So within Project Catalyst, one of the tools we have is a quality assessment, quality assurance tool that really looks at the systems change, what's in place in terms of policies, what are the practices. And it also serves as a guide, so it kind of pings people on some of the areas to consider as they really undertake a systems response. I know also Heal Trafficking, you offer comprehensive policies and recommendations for health systems that are undertaking this work specifically around human trafficking, and so those are also critical tools to look at for systems change. Another way that we measure outcomes is by measuring the impacts of the trainings. We have set curricula that we share with our state and territory leadership teams, and we're able to then evaluate the providers' change in practice, and we continue to do that down the line.
Okay, I did want to mention that in working with Project Catalyst and with Anna here, one of the great outcomes, qualitative outcomes that I noticed in these training of trainer sessions that they have, bringing together the federally qualified health centers and the domestic violence programs, was that they also brought in other community stakeholders who are addressing issues of violence, trauma, exploitation, human trafficking in the community. They brought in a number of legal teams that were working in human trafficking. They brought in a number of immigrant rights advocates who are working in human trafficking and intimate partner violence. And so building this movement, I guess this building capacity within the local communities to respond, I would consider a very strong outcome measure. And I don't know if you folks are measuring that when you in your assessments with your researcher.
Not exactly, but yeah, it is worth saying that that it is a multidisciplinary and collaborative approach. And as Kim just mentioned, there are a number of programs, especially that work with rural farm workers, migrant health do migrant health as well as other legal work at the state level as well as the county level. And those are key connections, both for healthcare staff and for community-based advocacy staff, because they're the experts who are really going to help those who want to pursue legal or criminal recourse. Having said that, legal criminal recourse is not for everyone, especially with people who have previous negative experience with different systems, whether it be courts or criminal justice. And so advocates are often a primary referral and a place for people to begin. As you probably know, for all of you on the phone today, there's a lot of moving back and forth and when making a change. It doesn't just, you don't snap your fingers and have it happen overnight. It's a process of change, and it really needs to be done with the support of an advocate because it can be dangerous. And actually, we know that when people are ending relationships or leaving an intimate relationship, that's when they're most at risk for being killed and for fatality. So advocates really help look at those critical safety pieces. And there is sometimes, very often, a process of change over time that happens by working with a client, working with an advocate. So that is, they're committed. Advocates are used to working with people in the long term to support them to get ready in the best way and the safest way for when they're going to make that change.
Perfect. We have another question from Victoria Felt, who writes, I work in a large FQHC in California and feel overwhelmed by all of this. One big issue is funding someone to get this off the ground. Any thoughts or advice on that? Victoria, I feel you, I hear you. We have those same challenges, but I think what you can start with is being a champion and advocate within your FQHC. I think Futures, do you provide technical assistance?
Oh, yeah, you can always contact us. I think what I would share, too, just like Dr. Chang was just saying, you're a champion, and there's other people in your clinic, I'm sure, who have an interest already in this topic and would be really motivated to learn more and be a part of a systems change. So try to identify the other people in your system, who are already warm, or maybe they're working on other social determinants of health or women's health issues more broadly, and really try to see if you can get a multidisciplinary group. Invite your local advocate into that meeting, whether you have a human trafficking specific program or a domestic violence program. Invite them to the table and just think about, as a group, how you can initiate this kind of work. And that online toolkit I mentioned, IPVHealthPartners.org, is really set up to help community health centers initiate this type of partnership. So I would just encourage you, it can't be done by any one person. They can't shoulder that work. And so it really takes a group of people, a multidisciplinary group. And so think about starting there. And maybe there is a film or something small you can use to introduce the topic to your staff and initiate a conversation and then go from there.
I'd also say, Victoria, please reach out to me at the national level with the National Association of Community Health Centers. We're very invested in this issue, and we have provided a lot of space for trainings and workflow developments and support for local FQHCs. Which FQHC do you work for? If you mind me asking, you could type that into the chat box. And also you can find my contact information on the slide deck. I guess I'm gonna end with what happened to my patient BK. So she didn't go to the hospital that night, and we at Asian Health Services really worried about what was going to happen to her. I had made a mistake. I thought that I had really just set this child out to her death because she was that sick. But because we are a community health center and we have connections with the community, we basically enlisted all of our health educators, our community health workers, our youth program coordinators, and contacted all the community members, found out where she was the next day, went to her, talked with her. Our health worker basically drove her to the hospital, and she was admitted. She was admitted for 2 months. On discharge, she survived, which is a good outcome. On discharge, however, she was discharged to jail, back to jail, county jail. And I'm not going to leave you on a bad note. I will say that since that time, California has enacted legislation to, 1, consider commercial sexual exploitation of the child as child abuse, 2, to put the commercial sexual exploitation of the child under the responsibility and jurisdiction of the child welfare agencies, and 3, to legislate that commercially sexually exploited children cannot be arrested for prostitution or solicitation. So big legislative changes have occurred since that time. And so, change happens. Change happens slowly, but it does happen, and it's because of all of you. Thank you so much.
Thanks, and don't hesitate to reach out if we can offer you any support on this topic at the National Health Resource Center on Domestic Violence. Thanks, everyone. Enjoy your day.
Thank you, ladies and gentlemen. This concludes today's event. You may now disconnect your lines, log off the webinar. Have a great afternoon.